Good evening and welcome to the Duncan G. Sinclair Lectureship in Health Services and Policy Research. My name's David Walker and I'm Director of the Queen's School of Policy Studies. I would like first to acknowledge the traditional lands of the Haudenosaunee and Anishinaabe peoples, upon whose land we live and work, and to acknowledge that we respect and are considerate of that truth that brings obligations. I wish also to say a few words about the Sinclairs, Duncan and the greatly missed Leona, without whom we would not have the opportunity to hear our special guest present the Sinclair Lecture today. Duncan's contributions to Queen's University and health policy in Canada are well known. Both our academy and the Canadian healthcare landscape bear his fingerprints, if not his footprints. And his energy, commitment, and contributions continue to this day. One example is the graduate course in health policy that Duncan and I teach together each year, where he attempts to subvert the minds of the next generation of policymakers toward reform and innovation. Some of you are here today, thank you. We even use our guest's book, Better Now. So thank you, Duncan. Your contributions are recognized by this lectureship, initiated by the then Medical Research Council and supported by the Faculty of Health Sciences and your family. And so to our guest speaker, Dr. Danielle Martin. Danielle's career as a physician and powerful advocate for intelligent change to our publicly funded healthcare services is seminal and well recognized. She's one of the most respected voices in Canada. You may note that I did not use the words healthcare system, since Duncan is allergic to the word system being applied in this context. Danielle is Vice President Medical Affairs and Health System Solutions at Women's College Hospital, where she practices family medicine. She's Associate Professor in the Department of Family and Community Medicine, the Institute of Health Policy Management and Evaluation, and the School of Public Policy and Governance at U of T. I would add that many Canadians felt great pride watching Danielle a few years ago defend the principles of this, our most precious social program, in front of the United States Senate subcommittee in a typically Canadian way, with quiet eloquence, facts, and passion. It's something well worth watching on YouTube. This led to a subsequent relationship with Bernie Sanders, about the details of which were not clear. And her recent contributions, you'll read The Lancet, no doubt, Canada's Global Leadership on Health, an enormous body of work which is very valuable indeed. So on behalf of Queen's School of Policy Studies and the Queen's Health Services and Policy Research Institute, whose director, Dr. Mike Green, will close the session, we thank you for being this year's Sinclair Lecturer and welcome you back to Queen's.
Thank you so much, Dr. Walker. Thank you all for coming through the snow and the sleet to be here this evening. I want to thank Dr. Pecora also for the hospitality today. And what an honor to be able to give this lecture in the presence of Duncan Sinclair, whose many contributions to the health of Canadians are well known, and I hope to do justice to this lecture that honors him. So we're all here this afternoon, this evening, because we care about, or some of us actually could rightly be called preoccupied or obsessed with, health. Individual health, of course, as a foundational element for a happy and productive life. Health systems, such as they are, as equalizers of opportunity across unequal societies. Health industries as economic drivers in our communities. But for Canadians, and this is something I learned after the very bizarre experience of going viral on YouTube, there is another function that our health systems serve. A function that's rather unusual, in fact, by international standards. Canadian Medicare, our set of single-payer insurance plans for doctor and hospital services across the country, is nothing less than a touchstone of Canadian identity. Canadians see it as a vital component of our social fabric and an expression of our shared values. So when I say that its importance is ingrained in our national psyche, I'm actually not exaggerating, and this is supported by empiric evidence, such as the 2012 Leger marketing poll that found that 94% of Canadians surveyed felt that Medicare was an important source of both personal and collective pride. But in case you doubt the evidence, you need only see my email inbox in the 3 weeks following that US subcommittee hearing to know what it is that one triggers in Canadians' emotions and in their pride, either when our system, as imperfect as it is, and we're going to talk a lot about its imperfections, is attacked or when it's defended. To me, this is a testament to Canadians' commitment to fairness, which I greatly value also, but I think at times it's also a challenge to those of us who love our system but know that we have to improve it. As a family doc working in the system, I believe that we do have a lot to be proud of, but I am not an advocate for the status quo. I think we all know that there are deep issues facing our healthcare systems that must be confronted. We hear it regularly from patients, friends, family, the media. We talk about it in the corridors of our policy schools and in the legislative assemblies of the nation. The senior living with chronic pain, waiting for over a year to get an appointment at a specialty pain clinic. The woman unable to find a primary care provider close to home who has to drive an hour to see her family physician. The construction worker who has to choose between paying his rent and paying for his medications. So our dispute really isn't whether our health systems need repair, because they're in constant evolution, which is as it should be. The question is how to address our challenges in ways that don't undermine our values. To do this, we need to challenge a lot of our traditional notions about the roles of hospitals and doctors. I say this as a doctor and a hospital administrator, about the ways that healthcare providers work together in our systems, and about what it means to help an aging population live a good life. Now, some of these ideas are not new that I'm going to be talking about tonight. In fact, they go back to the work of Dr. Sinclair and others that was done in the days of the National Forum on Health, and even further back, indeed, to the Hall Commission and the very foundations of Medicare. Some are new ideas, or perhaps you might call them new incarnations of old ideas that take into account technological advances, the rise of big data, and the rise of the digital age. What they have in common is that they're new ways of thinking about the work that we do every day in healthcare, and they challenge the status quo. And that's, of course, what makes them nearly impossible to implement. Because changing the way that you work is incredibly hard to do, especially when we've all grown somewhat comfortable with the present state, when many of us have earned our living from it, and when the structures that are designed to sustain it reinforce it so that we just regress to the mean every time. Now, this isn't a new observation. Dr. William Osler, one of the founders of modern medicine as we know it today, once wrote in a beautiful essay in 1906, and I quote, "The pain of a new idea is one of the greatest pains to human nature. It is, as people say, so upsetting. It makes you think that after all, your favorite notions may be wrong, your firmest beliefs ill-founded." And he was talking about the way that we understood the circulatory system to function, but actually it's no different in any part of health systems or health policy. That instinctive resistance to anything that is new or newly reincarnated is so often encountered in the healthcare sector, which is a sector that is fundamentally structured to minimize risk. But none of that makes it impossible. All across this country, including right here in Kingston, we see amazing examples of innovation that, if we could manage to scale them up, could put some of our biggest challenges to bed. So what I'd like to do with my time here today with you is to define some of those big challenges and to try to bring you some good news about what I think we can do in very concrete terms to address them. So to begin, what does the evidence tell us about the big challenges to the health of Canadians? Well, some of you may have seen the special issue of The Lancet that Dr. Walker referred to earlier, which was devoted to Canada, just came out last year. And this was a special issue about Canada that talked both about Canada's domestic health systems and our role in global health. And I had the immense privilege of working with a group of people from across the country on one of the two core papers in that issue. And we were asked, just put yourself in our shoes for a second to imagine the editor of an international journal saying to you, your job is, and do this in 3,000 words, articulate the major challenges in Canadian healthcare for an international audience, describe what it is that's being done about it, and use all the best available evidence. So given that challenge, we chose, essentially, we came down to three challenges. First, Indigenous health disparities are unacceptable. Second, wait times for elective care are too long. And finally, access to services outside the core of Medicare, meaning outside of doctors and hospitals, is uneven. I want to acknowledge the core importance of Indigenous health disparities here today on traditional Indigenous lands. As we saw in the calls to action of the Truth and Reconciliation Commission, the roots of those disparities do not lie solely in health or our health systems, but in colonization and its present-day manifestations. Of course, in the social and the economic determinants of health, and in our country's many unmet obligations to Indigenous communities. But in addressing the root causes, the solutions are also going to lie in building better healthcare systems for everyone, for Indigenous and settler Canadians alike, in partnership with our communities. Systems that are going to deal with congested emergency departments, with overcrowded hospitals. You have any patients in the hallways this week? We've got patients in not just in hallways, but in auditoriums and bathrooms and all kinds of locations in Toronto today. With patients lying on gurneys in hallways and cafeterias, with lack of accessible and primary specialty care, with waits for mental health services. So what's the solution? Well, if you read the papers, it seems that the answer is pretty clear. The answer is more, right? That's whenever people experience poor care in the system, it seems that the solution comes down to some version of more. We need more doctors, more MRI machines, more nurses, more hospital beds, more long-term care beds, more money. Now, I'm not going to argue that we never need more resources. I think there are places where incremental investments are probably needed in the health systems of Canada. But the core of what I've come here to say tonight is that nearly always we could be doing a lot better with the resources we've already got. In fact, ironically, sometimes more medication, more treatment, more resources has the opposite effect. It lulls us into complacency and forces us, or prevents us from making the hard decisions that we need to make to truly transform the system. It worsens patient experience, and it can actually reduce both quality and quantity of life. Those of you who've been following the Choosing Wisely campaign would know all about that. In my book, which Dr. Walker mentioned earlier, I talk about many Canadian patients whose problems would be very familiar to most of you in this room, and whose lives would decidedly not be made better with more. One such person is a woman I call Susan. Susan is a 75-year-old widow who lives in a small town in Saskatchewan. Her kids moved to the big city for work, so she's on her own. And as each decade has passed, she's accumulated diagnoses: diabetes in her 50s, lung disease in her 60s from smoking in her youth, a heart attack in her early 70s. Like so many Canadian seniors, Susan takes 8 different medications, she has seen 3 different specialists, and she needs to be on top of many elements of her care. But she's coping. In fact, she's coping really well. She never misses her bridge game on Tuesdays. She's got neighbors who give her a hand with the snow shoveling, and she's happy living at home. Now, one winter, Susan develops a cold, and she's starting to have a hard time keeping on top of eating and drinking. So she decides to call her family doctor to make an appointment. But he's away on vacation in Florida, and the message on the answering machine says, "I'm not back for 2 weeks. If this is an emergency, take yourself to the emergency department." And Susan says to herself, "It's just a cold. I'm not going to bother anybody by going to the emergency department." So she waits 3 more days, by which point she's feeling really very terrible, and she does eventually go to the emergency department, where she's found to be dehydrated, and so she's admitted. While she's in the hospital, she has trouble sleeping in a strange bed, and she's prescribed a sleeping pill by the very helpful doctor on call that night. Susan is confused and groggy as a result of the medication, and when she gets up in the middle of the night to pee, she falls, and what happens, David, the orthopedic surgeon? She breaks her hip. 2 days later, she has surgery to fix her hip. Post-operatively, her blood pressure's low, so the doctors stop her blood pressure medications. And she leaves the hospital with a prescription that contains the other medications, but not those blood pressure medicines that were stopped. And so she ends up not restarting them, thinking that that was an intentional move. And when she goes to see her family doctor, he, of course, has no idea that she was ever admitted to the hospital, doesn't know anything that was done for her in the hospital, and doesn't tell her that she needs to restart her medications. This arguably contributes to her second heart attack. The ensuing months consist of a series of hospital admissions and several weeks in the intensive care unit before Susan eventually dies. So it doesn't have to be this way, right? I mean, I see it. I know that you all see it too. If her family doctor had been around, but he's got a right to go on vacation. If a member of his team had been around, a nurse or a nurse practitioner or a colleague had been available when she first got sick, if he had had the information about what happened to her while she was in hospital in a timely way and the changes that were made to her medications, if she had been asked what her care goals were when she became increasingly frail, if she had been offered the option to die at home, any of those things would have made this a very different story. Susan didn't need more health care. In the end, she got more health care than any of us probably would ever want for ourselves or for our loved ones. Putting more resources into the same systems we have in place today will not yield something better for the thousands of Susans, including here in Kingston and in my own hospital in downtown Toronto, who suffer from care that is not poorly resourced, but rather poorly organized. So why do we find ourselves in the era of Susans? Well, I think it's pretty clear to all of us that Canadian patients have different needs than they did when Medicare was first taking root across this country in the 40s, 50s, and 60s. By 2041, nearly a quarter of our population will be over the age of 65. And more Canadians are living with chronic disease, just as Susan was doing. But we've built a system in which all roads lead to the hospital. And in fact, more specifically, all roads lead to the emerge. Hospitals and emergency departments are great places to get some kinds of health care. And if I, get mowed down by a truck, it's definitely the place where I want to be. But for people experiencing predictable exacerbations of chronic illness, hospitals are a terrible place to be. I have the pleasure of working at an unusual organization, Women's College Hospital in Toronto, where redesigning care is at the heart of what we do. And we have a somewhat unusual model, which those of you who know the Hotel Dieu model here in Kingston will understand a little bit, but it's slightly different. Our maximum length of stay at Women's is 18 hours. So as Ed Clark likes to say, we're a hospital without the hotel. We have no inpatient beds, and we have no emergency department. But unlike the Hotel Dieu, which has similar constraints, we are not affiliated with any one inpatient hospital. So instead, we've started to call ourselves the hospital designed to keep people out of hospital. Put simply, we believe that health can be found outside the captivity of the hospital walls. So let me describe what Osler would have called a new idea for someone like Susan. It's a place, a real place in my organization that we call, by the way, it's a horrible name, I'm taking nominations for better names. We call it the AACU, which stands for Acute Ambulatory Care Unit. And this is a special unit that's located pretty much where you would expect to see an emergency department when you walk into a regular acute hospital. It's right inside the first set of sliding doors. But instead of finding it jam-packed with people sitting in a waiting room or stretchers filling the hallways, it's actually quite a calm place. And we consider it to be functioning optimally when there's basically nobody in the waiting room. On a busy day, the stretchers and rooms are full and people are moving in and out, but they're moving in and out with the kind of rhythm of a clinic space as opposed to a hospital. And in this place, there is a person who is an internal medicine specialist who carries what I call the magical cell phone. And it's magical because it actually gets answered by a doctor who really wants to help the person on the other end of the line. This is the number that we give to the family doctors in our neighborhood and to the nurse practitioners who are providing care in our community and to the home care workers who are taking care of patients in their homes to call when they need to talk to somebody and get advice to take care of their patient in order to avoid sending that person to the emergency department. And when you call the number, a doctor answers who gives you real-time advice on how to help that patient sitting in your office right there and then, or the client who's sitting in front of you in the home. And it can be anything from advice on how to switch that person's medications or what to do over the next 48 hours in terms of symptom relief. And that same number will also help a family physician or a nurse practitioner get help coordinating home care for a patient or rapid access to imaging like a CT scan or an MRI today or tomorrow for a patient who essentially otherwise they would be sending to the emergency department. And if that patient is too sick to be managed in office or in the home, he or she can be sent in an organized fashion with an appointment time over to that AACU, either today or tomorrow. And they can have blood tests, they can have advanced imaging, they can have monitoring, they can have catheters and IV medications, any number of hospital-like services, but they will be stabilized, they will be connected with home care, and they will be sent home same day. These connections between the home and the hospital for urgent referrals and services play a vital role in avoiding unnecessary hospitalizations for people who are managing chronic disease. And it saves people time, and it saves the healthcare system money. So let's think about how a model like this would have helped someone like Susan. As she developed heart failure in her final months of life, and she was in that revolving door, into the emerge, up to the ward, stay for 3 days, go home again, back to the emerge, back up to the ward, stay for 3 days, that would have meant regular trips to the emergency department. She would go by ambulance, she would sit for 8 to 10 hours, she'd spend another 8 to 10 hours getting tuned up, she might get admitted, and then she would go home. But with a model like the AACU, her family doc, or the professional taking care of her at home, could have called that internal medicine specialist on the magic phone, and they would have gotten real-time advice. And if she had needed to come in for a tune-up, it could have been done in an organized way, and she would have been sent home again with a warm handover to the home care team. Another example of redesigning services to avoid unnecessary hospitalizations in the setting of chronic disease is our Rapid Access Addiction Medicine Clinic, or RAM clinics, that we work to launch and support across the province, including there's one right here in Kingston. Now, I'm sure I don't have to tell everyone in this room that addiction is associated with a tremendous amount of shame and stigma. And as a result, people are often hesitant to reach out and seek treatment. And often what happens is they land in the emergency department in a crisis of some kind. And we all know that that is a moment where very often, not always, they're open to getting help. And what do we do for a person who lands in the emergency department with a near-miss overdose or an injury, as the result of a fall related to their addiction? We do them the gift of putting them on a wait list for some kind of addiction treatment that might happen in a week or might happen in a month or even longer from that. And it's not uncommon, unfortunately, to see those same people back in the emergency department over and over again, sometimes having died from opioid-related complications. The RAM model, the rapid access model, turns this on its head. And the principle of this model is if you say you are ready for help today, you are going to get help today. And you can access it directly from the emergency department, or you can access it from your primary care provider's office, including through a magic number. You're going to hear there's a theme here where the physician can pick up the phone and call and get advice about getting you into counseling and get you started on anti-craving medication right there and then while you're sitting in front of them in the office. This allows people to see a healthcare provider within 1 to 2 business days. That's the model, 1 to 2 business days, rather than waiting weeks. RAM clinics like this also apply a multi-pronged approach to care, so you can access psychological counseling and you can access medical treatment for addiction in the same location at the same time, rather than creating a kind of either-or proposition. By creating a place like this where a referral isn't necessary, where a person can walk in, and where I am ready now for help translates to help now, it's amazing the kinds of outcomes that you can get. This model is now decreasing the burden on our healthcare system by reducing emergency department visits and waits. The 7 clinics like this that opened their doors in the province in 2016 saved the healthcare system hundreds of thousands of dollars, and the patients who were treated much more quickly. 2 years later, there are now 55 of these clinics across the province. I say this because I think it's important for everyone in this room to know there is a lot of terrific work going on. And in the communities where these clinics have been implemented, addiction-related emergency department visits and hospital stays are declining. Think about the meaning of that as we watch this wave of addiction-related issues marching its way across the country. In the early days of responding to the needs of people with complex chronic disease, people used to talk about this notion of wrapping services around the patient, which is something that I never understood what it meant, because as far as I could tell, it seemed to consist mostly of throwing more stuff at people, usually in the form of appointments that they had to keep track of, and making them full-time patients. Clinics and models like the RAM clinic and the AACU model are not about putting more services into people's lives necessarily. They are actually about wrapping services around the primary care provider, the home care provider, the circle of care that is helping the person to stay as well as they can be in their home, and building linkages between parts of the healthcare system that do a poor job of communicating with each other. So these are two examples from my own local environment of innovative projects that are being undertaken across Ontario to address some of the challenges that we face. And the challenge that we identify in our Lancet paper, which you didn't need to read the Lancet to know about, of long wait times for elective care, can similarly be addressed through more intelligent use of existing resources. It's funny, unlike other industries, healthcare has not adopted effective strategies for managing queues. And I'm sorry to say that I was a consumer of the news stories that went, hit the national press around people waiting some horrendous length of time. I think it was for neurology consultations here. So that probably touches a nerve for some folks in the room. But these are the kinds of stories that we see every day on the front pages of our newspapers, right? And yet the data are there, and we know what kinds of interventions reduce wait times, and many of them do not involve more resources. Good examples include e-consultation, in which family docs or primary care providers send a quick question to a specialist electronically, rather than referring the patient for a face-to-face visit. So the person never gets on the wait list, because actually, I say this as a family physician, huge numbers of the questions that we have for patients can be answered in a 5-minute phone call with a specialist or a quick email exchange. Or centralized intake for those issues that do require a face-to-face intervention. So centralized intake, I'll pause on this. I suspect that some folks in this room are experts and some have not heard of the concept before. And the example that I like to use to illustrate the case is the difference between the grocery store and the bank. So when I'm on my way home to pick up, a few things on my way home for dinner that evening, I go and I grab a bunch of stuff at the grocery store and I put it in my cart, and then I start doing that dance, at the checkout counter, trying to figure out which of the 6 lines is moving most quickly. And if you get accidentally trapped in the line where the person is going on break, or there's somebody counting out like 1/4 at a time, you know that you're there for another 20 minutes and you're watching the other lines, go through. And it can make a difference of 20 minutes at a time of day when it really matters to me. But if I go to the bank, on the rare occasion that I go, to interact with a human being and a teller rather than just using electronic banking, there's a single line, right? And I am seen by the next available teller. This is queuing theory. The banks have figured it out, and the grocery stores have not, except apparently for Whole Foods in Manhattan, somebody told me. So when you adopt the single common queue or centralized intake, the principle is that you are seen by the next available provider who can deal with your issue. And it does require, speaking of the pain of a new idea, it does require both referring physicians and patients, as well as specialists, to rethink the notion of a referral as a personalized introduction. I'm going to send you to Dr. So-and-so because I went to medical school with him and I know he's the best. Usually I say that on the basis of absolutely no empiric evidence whatsoever. But I know him and he sends me back nice referral letters or whatever in a timely fashion. We move away from that and we say, for people with like problems, we have expectations around quality that we monitor and we assure, and the patient is seen, unless there's a really good reason why it has to be Dr. X, they are seen by the next available, often these are for procedural issues, the next available surgeon or proceduralist who can take care of that issue. And just doing that alone, even without increasing the funding that you put into the system, has been shown to have quite impressive effects. And indeed, I think you use this in Kingston for hip and knee replacements, but in Winnipeg, they use it for all endoscopy. There are all kinds of examples across Canada of places where centralized intake and assessment are being used in ways to reduce wait times. And when you add the additional magic ingredient of a full range of healthcare providers, so non-physician team members operating to their full scope of practice, physios, nurses, occupational therapists who can participate in that assessment and triage process, so that you're using the physician or the surgeon for the part where you really need the physician or surgeon involved, you can actually unblock a lot of these seemingly difficult wait time problems. And so, yeah, we're using them in Kingston, but we're using them for one or two things. Imagine what we could do if we were using this approach more broadly. My point here is not to say that these are the solutions for every single thing. My point is to say that there are projects that are very successful, solutions that are within our reach, that are not magical, that we all know work, and we don't need permission from the Ministry of Health to implement them, and we don't need more money. What we need is the courage to think differently, to engage with that pain of the new idea, and to take on that leap, if you will, of doing things in a different way than we did them yesterday. And of course, even once we've done that, what we find is that you have a successful project in one community and then everybody else keeps doing the same old thing that they've always been doing, which is why Canada has famously been called by the Honorable Monique Bégin and many others a nation of pilot projects, consistently unable to scale up and spread new solutions widely across the country. And I know that this is something that Dr. Chris Simpson has spoken about extensively as a physician leader here at Queen's. It's such a missed opportunity because, and I'll say this, that I've given a lot of talks across the country since this book came out last year, and it's amazing to me how people stand up in these auditoria, and you're at the Roxy Theatre in Saskatoon on a snowy Thursday night, and somebody stands up and says, well, I don't know what it's like. I'm sure your ideas are good in other places, or maybe it's good for downtown Toronto, but in this community, we have problems finding a family doctor. And I think to myself, oh my goodness, there's not a community in the country where that's not an issue, right? Our problems are not all that different, across the nation. And so actually, there's a lot that we could be learning from what's been successful, not even overseas, folks, but just down the 401 from where each of us is working. The key to each success is to resist the old idea, the idea that more is always better, that more is the answer to our challenges. To challenge that assumption and instead ask ourselves, what could we do differently just with the resources we've already got? And I've got a piece of good news for you about this, which is that I've learned that Canadians are already there. They're actually prepared to be challenged in this way. They find it interesting. You describe something like centralized intake to people and you watch them think to themselves, I had never thought about it in that way before, but it makes sense. And they are prepared to participate in the implementation of new ideas if those of us who work in the healthcare system day to day are prepared to go with them. And my favorite illustration of this occurred when I was in Ottawa at the very beginning of my book tour journey last year, and I was the end of a lecture and sort of milling around talking to people, and this group of women came up to me and they had their copies of my book under their arms, and there were little colored sticky notes sticking out the side of it. And of course, this was a book club of retired nurses who, in my opinion, should run the country. And they had come to my event with a very concrete thing to say. They had come to say, we read your book, we agree with your ideas, what can we do? And I was floored and moved, and I have to say I was also completely unprepared to answer that question because I thought I was writing a book. I didn't know that I was trying to start a movement. And until that moment, the penny hadn't fully dropped for me that actually the only people who could carry these ideas, the kinds of ideas that we're talking about tonight, were these women. It's regular Canadians, the ones who are on the waiting list, the ones who are lying in the gurney in the hallways, the ones who are sitting in your waiting room in the family doctor's office, who are going to say to us, why don't you have an email address? Why did I have to make an appointment to come here to get a simple thing taken care of? Why is it that I waited 4 months to see Dr. So-and-so, and the person down the street I know very well saw a new graduate who had a 2-week wait time? Why can't you people get it together to organize yourselves differently? Those are the ones who are going to push us to do things differently. And there are millions of those people across this country who are ready and willing to engage with us and to support health system leaders if we're ready to take some bold action. So the processes and procedures that we've come to rely on in healthcare are not set in stone. A very brave and principled generation before ours created our current healthcare systems, such as they are, and removed the burden of paying for care from the shoulders of their children. Surely we, in our generation, can be the ones to modernize it. So as we go to work or to school, always doing the best we can, I think we tend to forget that our obligation is not just to do a good job of our job today, but actually to be agents of change. In our own organizations, yes, but also as advocates for the kind of change that's really needed to improve health in this region, in this province, in this country. So how do we change the system according to our values? How do we ensure that more Canadians have access to better care? Through innovation, yes. A lot of it not that new, a lot of it not that crazy to implement, but by rethinking how we offer this care and how do we challenge our ingrained assumptions about the way we do things. As painful as it can be to let go of old notions to make space for the new, I believe that health outside the captivity of the hospital walls is possible, that more health can be found out in our communities if we are prepared to put our resources there. That's the journey that I'm on and that my organization is on, and I want to invite you to join us. Thank you.
Thanks so much, Danielle. That was great, and I'm sure there'll be a lot of questions. Just so people know, we have about half hour or so for questions, and then there's going to be more opportunity to mix at a reception downstairs afterwards. It's a small space. We don't have a central microphone, so if I could ask people who want to ask a question, you could raise your hand, and then when I point up, you could stand up, introduce yourself, and ask your question, then we'll kind of carry on that way. So I don't know if there's anyone who wants to go first. Yeah.
At least from what I have heard, I'm a leader practice. I am a basic scientist, not an MD. Anyway, what I have heard from my family doctor and others is that in Kingston it is very hard to access specialists, even electronically. How is this going to be fixed? Even electronically.
So one thing that is amazing about the world of electronic is there's nothing that says that the specialist has to be in Kingston, right? In fact, I'm going to be a heretic and say that there's not even anything that says that the specialist needs to be in Ontario, although there are important licensure issues that need to be sorted out there. But nevertheless, you know, when we open up to the possibility that the primary care provider who knows the patient best can serve as an intermediary between patient and specialist, actually the list of folks that that person can access is as long as the entirety of the website of the College of Physicians and Surgeons of Ontario. And I know, because I receive mail constantly from new graduates who are looking to drum up business, that there are lots of folks out there who would be very happy to participate in such models. So I think the question that you're asking is, what do we do if we're only utilizing our informal networks? So I only know 3 orthopedic surgeons, and none of them will reply to my, sorry to pick on orthopods, none of them will reply to my email. But actually, if we're doing these, electronic referral models in which people roster or register onto a list of specialists who are prepared to answer, you can be accessing a specialist anywhere in the province of Ontario to answer your question. So I wouldn't accept that answer from your family physician. I would go back and respectfully challenge it again.
For example, to take one here, for example, the breast cancer surgery, there may not be anywhere in Canada where it could be referred. Of course, that cannot be done electronically. Surgery doesn't work electronically.
It doesn't, but surgery is cancer surgery is a good example, actually, of there's been quite a transformation in Ontario in the last several decades in terms of access to cancer care, such that things are quite regionalized now, and people do it pretty much is through centralized intake that these referrals happen, and so people are given the next available appointment, and we've seen quite dramatic improvements actually in cancer outcomes in Canada in the last number of decades. So I think that's a really good example of what happens when you take a non-system and you put a system into place. It's amazing how much you can improve outcomes without necessarily having to put a lot more resource in.
But still,
Question over here in the back, and then we'll come to Richard.
Yes, please.
Thank you very much for Redesigning's policy school. My question has to do with mental health. So in your third one was about issues and services that are outside the core model now. Some of those are in the mental health area. But even those mental health services that are currently in the core there's all kinds of dysfunction and discontinuities. And we all have examples, like we take some examples
Thank you. It's an excellent question, and an area that I would say is ripe for transformation, our non-system of mental health care. And I'm just going to speak about Ontario now, but much of what I'll say I think applies more broadly across the country. One of the problems that we have, of course, is that as a function of the way that Medicare is structured, people can access a psychiatrist in theory without, having to worry about paying for it. But as soon as you're out into the world of psychologists, social workers, other mental health care providers, you're kind of on your own, and you're dependent on often employer-based coverage if you're lucky enough to have it. And even then, it's usually very Swiss cheesy and there's not much of it, et cetera. And so we really get into serious access problems and then long wait times with very little differentiation between folks who are severely mentally ill and really struggling. We don't do a good job of matching the intensity of the resource to the intensity of need. So I'll give you a good example. In the area of mild to moderate depression and anxiety, there's actually quite good evidence that online cognitive behavioral therapy, mindfulness-based stress reduction, and in certain subpopulations are very effective. And yet you are just as likely to find someone on a wait list for a psychiatrist who's got a mild to moderate, situation as you are someone with really severe problems, because we're not, again, in any way organizing these things. So in a perfect world, we would be using, this is a place where virtual care has the tremendous possibility for impact. There's a thing called the Big White Wall that you should all look up later on, freely available now to all residents of Ontario, which we evaluated at our Innovation Institute at Women's College Hospital. It's a set of online mental health resources that came from the UK. We evaluated it here. It's now being made available more widely. And it's a great example of the kinds of ways that people can engage in mental health support services without necessarily having to get streamlined onto a list waiting for, provider X or provider Y. Similarly, we know that case review models in which psychiatrists or other professionals provide, again, support and advice to a primary care provider is another great way of doing it. So you can have a psychiatrist who consults to a group of family physicians who can run through 10 cases in an hour and say, try this, try that, try this, try that, rather than doing a 90-minute assessment face-to-face with the patient, him or herself. And then you end up using those very, scarce and expensive resources for the people who need it most, and what you want is immediate access when somebody is really going off the rails. But the problem is we just have this one hammer, which is the doctor and hospital hammer, and we keep aiming it at everything that remotely looks like a nail. So we need to start thinking differently about the alternative forms of service. And I think mental health is an excellent example, especially because in most cases, not all, but certainly many cases, you don't need to have the provider and patient in the same room in order to complete a thorough mental health assessment. So, the capacity for transforming access to care in Indigenous communities and rural and remote communities, with new moms postpartum at home with a newborn who shouldn't have to even, schlep on the TTC across the city of Toronto, let alone further than that when they're trying to, get access to help for their postpartum depression. These are the kinds of problems that we're really engaging with in our Innovation Institute at Women's.
Thanks, Richard. You have a question?
Richard Resnick, Health Sciences. I'm wondering if I could bring three of your points together and culminating in the question. You talked about us being a nation of pilot projects. And then you talked about the issue of cognitive dissonance and resistance to change. And a theme that thread through your talk was the issue of getting on the exponential curve of digital transformation using digital health. So my question is, if we follow that trace, there's been tremendous resistance and it's not happening. It's not happening by, there's not enough of a coalition of the willing. So I'm wondering about your opinion about legislating change and what the role of governments have in pushing those pilot projects through legislation and challenging the health professions to move faster.
Thank you. So I'll say a couple of things about that. I mean, there are lots of levers, we use almost none of them. So we don't use legislation much, we don't use regulation much, we don't even use funding much. If you think about, I mean, when was the last time that we truly transformed the way that we pay we've got, small amounts of QBPs and small amounts of activity-based funding and small amounts of this and that, but we're, truly, if on the digital health front, for example, really thinking about how would you change what you pay for in order to try to get what you need. I don't think we've been particularly effective yet at using any of those levers. Having said that, I worry that we placed. I guess what I'm going to say is you need both the top down and the bottom up. So we learned this experience actually from the implementation of surgical safety checklists in the province of Ontario. So surgical safety checklists, which came from the the global health evidence, very compelling evidence that you could reduce surgical mortality by as much as half or maybe even more if you implement a simple checklist. Is this the right person? Are we doing the right procedure on the right body part? Who's in the room? All of this kind of, did they get the antibiotics? All this kind of stuff. You do a bunch of stuff before the operation and a bunch of stuff after the operation, and it's literally check boxes. Massive reductions in mortality. And Ontario actually courageously said, we are going to make this a requirement. So, I think it was through the Excellent Care for All Act, but you might know better than I would, Richard, that, all of a sudden from one day to the next, it was the law of the land that every hospital in Ontario would implement surgical safety checklists. And what happened? Nothing. No statistically significant difference in mortality. Now, is that because our mortality rates were already, reasonably low? Maybe. Is it because of other factors? But one of the things that researchers have posited as a possible explanation for this is that it was implemented from on high, and there were no champions on the ground. And so people would kind of go through it by rote, but nobody really cared. Nobody had bought into the concept. There was no drive from the front lines that this was an issue that we want to address together. And so I guess my answer is unsatisfyingly, yes and. Of course, we need to use the big levers of power more effectively, but I think we cannot fail to also organize from the ground up, which is part of the, part of the reason why I think patient engagement and public engagement are so important here, that people have to demand it. Providers do and patients do.
A bunch of here and then over there.
Okay, thanks so much for your book and thanks for your presentation again. And my concern is with dental care, given that my husband has dementia and he was in KGH for 2 years, and it resulted in him having to have a total extraction because there was no long-term care bed, and I'm assuming that it's better in long-term care, but there is really a lack of dental care in hospitals. People used to have dentures, and now more and more with the aging population, people have teeth. And I'm told that the training is inappropriate for the nurses, and like his teeth rotted off at the gum line, and he swallowed them because his teeth weren't being brushed. And I assumed, as his wife, that his teeth were being brushed. So we have now formed a small task force, and we've spoken with Mark Gerritsen, and he says, fine, but pharmacare